morning, everyone. I'll be presenting on the topic Anapneo. Presenting Miss F, a 24-year-old student from Vellore, who presented with complaints of fever for 1 week, cough with expectoration for 1 week, dyspnea for 3 days. She was well 1 week prior, after which she started developing high-grade intermittent fever with chills, with the maximum recorded temperature of 104 degree Fahrenheit, and the temperature was temporarily relieved with paracetamol. She also had cough with expectoration, which was productive cough with an yellow expectoration. There is no history of hemoptysis. Uh, Prior to presenting here, 3 days prior, she developed progressively worsening breathlessness, and that's why she was admitted to the hospital. Otherwise, she did not have any known comorbidities. She has documented drug allergies to doxycycline and piperacillin tazobactam. Treatment history: on day 5 of illness, she was hospitalized to outside hospital. She was empirically started on injection meropenem. On day 7, her doxycycline and azithromycin were added to her initial antibiotic regimen. On day 8, she developed worsening breathlessness with increasing oxygen requirement, and that's why she was referred here. Throughout the hospital stay, she had persisting fever, no hemodynamic compromise. Outside fever workup for dengue, typhoid, and scrub, dengue, typhoid were negative, and scrub IgM was positive. Outside HRCT showed right middle lobe consolidation and anterior segment of bilateral upper lobe and superior segment of bilateral lower lobe showed ground glass opacities with reactive mediastinal lymphadenopathy. On examination, when she came to ED, she was in respiratory distress. Her vitals were a blood pressure of 130 over 80 millimeters of mercury. Respiratory rate was 48 breaths per minute. She was saturating 80% on room air, which was improved to 100 on NIV. She was tachycardic with a pulse of 148 beats per minute, and her temperature was 102. On general physical examination, pallor was present. However, there was no evidence of icterus, clubbing, cyanosis, generalized lymphadenopathy, or pedal edema. On systemic examination, there were bilateral infrascapular crepitations heard on auscultation. The rest of the examinations were unremarkable. So she presented with a clinical syndrome of fever, cough with expectoration and breathlessness. Community-acquired pneumonia was considered. So a viral pneumonia with superadded bacterial infections like staph, Klebsiella, and Pseudomonas were considered as differential, followed by Legionella, Mycoplasma, Chlamydia. Fungal, less likely as the patient was immunocompetent. This is lower down differential. So we investigated further. Initial counts were complete blood count was normal. She had mildly elevated transaminases. All the bilirubins were normal. Normal renal functions. Mild hypokalemia, and her procal was elevated 23.15. So this was an initial chest X-ray which showed bilateral opacities in the lower zone. So in ED, in view of worsening respiratory distress and hypoxemia, she was started on NIV. She was initiated on a broad spectrum cover which involved meropenem, linezolid, oseltamivir, doxycycline, and azithromycin. In the ED itself, she rapidly progressed to severe type 2 respiratory failure requiring endotracheal intubation and invasive mechanical ventilation. And she was shifted to ICU for further management. In ICU, she progressively worsened, and her type 2 respiratory failure was not improving despite proning and oxygenation measures. And oxygenation was poor with progressive hypoxia and low tidal volumes. And in view of refractory hypoxemic respiratory failure, she was initiated on venovenous ECMO on 14th. So her infective workup wise, her blood cultures, 2 sets showed no growth. Bloodborne virus screen was negative, and PCR for respiratory virus was negative, and her endotracheal culture showed normal flora. So before initiating ECMO, the biofilm panel was sent on the ET aspirate, which detected Mycoplasma pneumonia. So our final diagnosis is community-acquired pneumonia, causative organism being Mycoplasma, causing severe acute respiratory distress syndrome. This patient initially presented with community-acquired pneumonia and the organism being Mycoplasma. And we all know the first line agent for this is a macrolide, and she was initiated on the same. However, this patient progressed to severe type 2 respiratory failure, and she was not improving. So this brings us to the topic of discussion for today, which is macrolide resistance in Mycoplasma pneumonia. So macrolides in general, they are susceptible to resistance because there were few point mutations in few positions of domain 5 of peptidyl transferase loop in 23S ribosomal RNA gene. And also at the location of macrolide binding to 50S bacterial ribosome subunit, which reduces the affinity of the antibiotic towards the ribosome. So generally, we do not actively investigate for a macrolide resistance, or we don't confirm it through PCR. So there aren't much studies which come out which show this macrolide resistance, except for few studies which are published from China. So this was a study published in 2017 in Journal of Thoracic Diseases, which is from China, where 520 adults presenting with community-acquired pneumonia with a mean age of 45.7 years were investigated, out of which 14.42% were confirmed to be Mycoplasma pneumonia positive. And in the study, macrolide resistance was seen as high as 80% for erythromycin and 72% for azithromycin. However, tetracycline, minocycline, and quinolone had no signs of resistance. Further, there was another study from Japan which investigated around 1,500 patients through a mycoplasma pneumonia pandemic. So here we see the study mainly looked at how many patients are being switched from a macrolide or switched from a quinolone or switched from tetracycline. So in the study, around 52.8% patients who were receiving macrolide were actually switched to either a quinolone or tetracycline. Whereas this switch was not found when patients were initiated on quinolones or tetracycline alone. And this is another study published in China where they looked at adult patients with more than 18 years who were diagnosed with Mycoplasma pneumonia. Here again, the resistance was seen as high as 71.7% for erythromycin and 60.4% for azithromycin. And they have also noted that the point transition of A2063 gene 23S ribosomal RNA gene was the main reason for high prevalence for macrolide resistance. This is again a case study where a patient similar to us was reported from Japan. So 39-year-old lady with no comorbidities was found to have fever and productive cough. She was hospitalized 3 days after onset, and her admission vitals were stable with a chest X-ray and CT images showing a subsegmental consolidation in right lower lobe. She was initially initiated with ampicillin, sulbactam, and azithromycin with an initial diagnosis. However, her fever did not subside and the pulmonary lesion was extending. She was pulsed outside, but she did not show any improvement. But on clinical day 14, her mycoplasma titers were elevated and BAL examination was positive for mycoplasma antigen. So she also had a severe life-threatening mycoplasma pneumonia, similar to our patient. So when the antibiotics were upgraded to levofloxacin and tetracycline, her symptoms improved. And the molecular identification again showed the mutation in A2063 gene in the 23S rRNA. So our patient had a severe ARDS, and we probably attribute her clinical worsening to the macrolide resistance. So following the, as her mycoplasma and pneumonia PCR was positive, she was initiated on levofloxacin and she was not responding to macrolide regimen earlier. And meropenem was also added to cover for her common bacterial pathogens. And after 5 days, she was decannulated and she was extubated. And her clinical course was complicated by a hospital-acquired pneumonia for which she received polymyxin. So levoflox was given for a total duration of 14 days, followed by which patient clinically improved and she was discharged. So my learning point is that when a patient presents with atypical pneumonia, skin rash, neurological signs, and low oxygen saturation, if they do not improve with beta-lactam, suspect mycoplasma pneumonia. And if patients are not responding to first-line therapy, a macrolide resistance needs to be considered. Thank you.
Thank you, Feneeshiah, for that case. Any questions from the audience? So what was your clinical syndrome?
It's a syndrome of lower respiratory tract infection, community-acquired pneumonia.
Yeah, it was more like a bronchopneumonia.
Yes.
That's why you thought of atypical. It's more like a bronchopneumonia. That's why you thought of atypical organisms. Because your take-home message is in patients who are not responding to first-line therapy, macrolide resin needs to be considered. I mean, it's a strong message. The studies which are done from China, when were they? Which was it like before COVID or after COVID or
It was before COVID.
before COVID? So even before COVID, the resistance rates were quite high. So how often do we see mycoplasma in our center?
It's rare.
So any background work you have done?
No.
Okay. Yeah, so it's not a very common condition, though often we do suspect mycoplasma. And because of biophy, I think we were able to get a diagnosis. Did you ask them to do a 16S rRNA for this patient? No. Okay, in that way, we could have actually, probably got the resistance also in that way. Yeah, so this patient was not improving on azithromycin, and then levoflox was started. And was the levoflox and polymyxin started at the same time? I mean, just to know whether the patient had probably a pneumonia and then developed a hospital-acquired pneumonia, which actually pushed this patient into a severe hospital-acquired pneumonia. And then is it the polymyxin which made the difference, or it's the levoflox? I mean, that was worry because to say whether the levoflox made the difference or the polymyxin made the difference. The patient developed an hospital-acquired infection, and where we treating the hospital-acquired infection or the resistant bug becomes a question. So, what was the time frame? Were both levoflox and polymyxin started at the same time, or
No. It
levoflox
was
started
earlier.
earlier, and patient showed improvement?
Yeah, where she was given doxycycline as well as another broad spectrum antibiotic. I think it was piperacillin tazobactam, which was later upgraded to a carbapenem. The initial syndrome showed continuous worsening day by day. There was never a time where she was well, she was afebrile, she got better, and then another high spike of fever started, and then there was worsening hypoxia or so. So the 4 or 5 days she was here, there was progressive worsening of a condition, which is when she went on BiPAP and she was shifted here. And within a day of coming here, she required intubation. The X-ray findings also showed progressive worsening as opposed to clearing of some opacities and then new opacities. And the CT that was done in Naruvi, which was compared to this, we did not repeat a CT. Even the CT was showing more of an interstitial plus some bronchopneumonia pattern rather than solid consolidations like a hospital pneumonia. When she came here, we had started her on polymyxin straight away because she was in another hospital already, along with azithromycin. Doxycycline we didn't give because there was a concern of a reaction that was being
mentioned in the
so polymyxin was started straight away, meropenem, vancomycin, and azithro. On that, she continued to worsen. And that is when we thought about, okay, could this be a resistance? By then, the mycoplasma PCR also came. And then in consultation with ID, we started the levofloxacin. So the levofloxacin was started, I think, at least 24 to 48 hours after her admission. We don't know if she had resistance. We don't know if levofloxacin is the one that actually made a difference. It might be just the time that we gave her body to recover. But we thought it is important to highlight the fact that there is azithromycin resistance being reported from other parts of the world, and it should be a concern in case in a confirmed patient with mycoplasma, they're not responding to macrolide. Now, then again, why didn't she respond to doxy is another question. Doxy resistance is not really discussed.
It's interesting. It's good that you brought this up. Thank you, Feneeshiah.
So I also want to commend the complexity of the case and the team for taking so much to invest in to actually got her through the ECMO. A lot of unusual aspects along the way. When would you suggest that as medicine physicians, we send this biofilm test? How has the team thought about it? What are the recommendations? What does it look for? Actually, something that I'm also getting used to. Be useful for us to. Okay.
But when we sent it, it was not being offered. It came up later. We actually sent the CSO biofire in a ET aspirate after discussing with the microbiologist because we were not able to get a diagnosis and did not know how to
we
proceed.
do it in a critically ill patient,
Yeah.
not in a.
I think the recommendation should be similar to COVID testing.
Okay, so it's still a gray area or something for us to deliberate on.
Yeah, it's still a
Sure.
gray area.
And it's expensive also, cost around 13,000.